Bismillahirrahmanirrahim. The topic of today's lecture is non-syndromic keratodermas. I will be discussing acquired keratodermas today. And in the next lecture, I will be discussing syndromic keratodermas as well as porokeratosis and the related disorders. So let's start today's lecture. A definition and diagnostic approach. Palmoplantar keratodermas form a heterogeneous group of hereditary and acquired disorders that are defined by excessive epidermal thickening of palm and soles. So as the name signifies, palmoplantar keratodermas means thickening of the skin of palm and soles. It is observed as an isolated phenomena or part of a more complex syndromic phenotypes. So the syndromic phenotypes we will be discussing next time. Inherited classical palmoplantar keratodermas are characterized by prominent and predominant palmoplantar involvement that are differentiated from acquired palmoplantar keratodermas. So usually the hereditary palmoplantar or inherited palmoplantar keratodermas are present since early life. And acquired palmoplantar keratodermas, of course, are acquired later on due to different causes, which we will be discussing today. So this is a classification taken from the Rook of the non-syndromic forms of palmoplantar keratodermas. And the significant palmoplantar keratodermas in this classification are the epidermolytic palmoplantar keratodermas, the Pachyonychia congenita, then non-epidermolytic palmoplantar keratodermas, which include the Mel de Meleda and other variants, Loricrin keratodermas, the striate and focal palmoplantar keratodermas, punctate palmoplantar keratodermas, spiny keratodermas, marginal papular keratodermas, Coase disease, and transient echogenic keratoderma. Transient echogenic keratoderma. There are different clinical presentations of palmoplantar keratodermas. The first and the most common and the most and the one which is most familiar to us is the diffuse keratodermas, in which the whole palmar and plantar epidermis is uniformly thickened. But diffuse keratodermas is not the only type of keratoderma. There are focal areate or nummular keratodermas as well, in which the areas of palmoplantar skin under pressure is disproportionately thickened. So such kind of keratodermas are specific, or it has a special features that it causes difficulty on walking as well. Then there are striate keratodermas, in which the lesions are longitudinal and they are seen particularly on the flexor aspects of the fingers and on the flexor tendon. Then there is another type of keratodermas which are called as punctate keratodermas. Punctate keratodermas are characterized by multiple small scattered discrete long lesions. And the punctate lesions are smaller and discrete as compared to the focal, areate, or nummular keratodermas. The nummular keratodermas are particularly present on the pressure areas, while punctate keratodermas are present anywhere on the plantar or palmar skin, and they are small and discrete. Transgradient keratodermas. Transgradient keratoderma is the term which is used to describe the palmoplantar keratodermas that extend beyond the palmoplantar skin. Which is extend beyond the palmoplantar skin and can be seen on the knuckles as well as on the elbows and knees. Confluent hyperkeratosis is a mixture of palmoplantar keratodermas and transgradient keratoderma, where the whole digit is involved in hyperkeratosis, both the ventral as well as the dorsal surfaces. Then there is a type of palmoplantar keratodermas which are called as the cicatrizing keratodermas or mutilating keratodermas. These keratodermas are characterized by constricting bands around the digits. Such pseudoanhymes is found in many severe transgradient keratodermas, and it is not classical of any one type of syndrome. The generalized diagnostic aspect and morphology. Water retention by abnormally keratotic and porous stratum corneum contributes to the maceration and microbial overgrowth. Since in all keratodermas, the main feature is thickened stratum corneum, this thick stratum corneum is capable of absorbing lots of water and hence become thickened and macerated on immersion in water, as well as is a source of microbial overgrowth, both fungal as well as bacteria. And sometimes we have to look for other features which is not particularly important in non-syndromic keratodermas, but are more important in syndromic keratodermas. So whenever you see a patient of palmoplantar keratoderma, you have to see the oral mucosa, the nail, hair, teeth, and the ability to sweat. Biopsy for histology of ultrastructure still plays a critical role in diagnosis of keratodermas as it provides the essential clues for further genetic analysis, particularly distinguishing between the epidermolytic keratodermas from non-epidermolytic keratodermas. Now, the first non-syndromic palmoplantar keratoderma which we are going to discuss today is the epidermolytic palmoplantar keratoderma. Epidermolytic palmoplantar keratoderma is probably the most common form of diffuse keratodermas. It is shown to result from rare mutation in keratin 1 and sometime in keratin 9 gene. There is a disruption of intermediate filament integrity that reduces the resilience of cytoskeleton to minor external trauma and hence resulting in blistering. So this feature is similar to the bullous ichthyosiform erythroderma, where in addition to erythema and ichthysis, there are chances of developing blisters. Diffuse keratoderma develop in infancy. In adults, there is confluent keratodermas, which are sparing the dorsal surfaces with a sharp demarcation and an erythematous margin. Blistering is, however, not a major feature. Hair, teeth, and nail are normal, but knuckle pads and nail changes were found, which are, of course, not significant. Moreover, limited transgradient lesions, for example, on Achilles tendon, may be referred to as the Grether's keratoderma. Otherwise, epidermolytic palmoplantar keratoderma is not characterized by any transgradient lesion, but sometimes the transgradient lesions like on Achilles tendon may be present. So this is the peculiar histology of all the epidermolytic hyperkeratotic disorder. There is massive hyperkeratosis and there is a split at the level of stratum granulosum and there is a degradation of stratum granulosum. And epidermolytic hyperkeratosis is seen in congenital bullous ichthyosiform erythroderma, in epidermolytic keratodermas, in linear verrucous epidermal nevus and epidermolytic acanthomas. And these are the only disorders in which the granular layer is affected with loss of granular layer and a blister or a split beneath the stratum corneum and above the stratum spinosum. The mainstay of management is mechanical debridement followed by mild keratolytic reduplication to avoid the fissures. Oral retinoids can be tried in low dose, but excessive peeling may be a problem. Topical calcipotriol may be of little help. Then a very commonly asked disorder, both in the clinicals as well as in written exam, is the Pachyonychia congenita. Pachyonychia congenita is a group of autosomal dominant keratinizing disorder, which is characterized by mutation of a number of keratin genes like 6A, 6B, 6C, 16, and 17. The variable clinical features affect a number of ectodermal structures that include nail bed, oral mucosa, palmoplantar skin, teeth, and pilosebaceous units. Hyperkeratotic nail dystrophy is the mainstay of the main feature of Pachyonychia congenita, and the name is derived from this hypertrophic nail dystrophy. However, the most problematic manifestation of the disease is focal plantar keratoderma. So the point to understand is that the hypertrophic nail changes is the main feature of Pachyonychia congenita, which will be seen in all type of Pachyonychia congenita. While focal plantar keratodermas is seen only in type 1 Pachyonychia congenita, which is also called as the Jedison-Lewandowski's Pachyonychia congenita. In addition to palmoplantar keratodermas, type 1 Pachyonychia congenita is also characterized by oral leukokeratosis. There is another type of common type of Pachyonychia congenita, which is called as type 2 or Jackson-Loyer. And in type 2 or Jackson-Loyer, in addition to the nail changes, there are large pilosebaceous cysts like steatocystomas and presence of teeth in the neonatal period. The three clinical features that are reported in 90% of the patients of palmoplantar keratodermas are the toenail dystrophy, plantar keratodermas, and the plantar pain. The patient older than 3 years, these features are highly diagnostic. The thickened toenails, that is hyperkeratosis of the nail bed, appear within the first year or up to 9 years of life. Of note in many cases that all 20 nails are not involved. Plantar keratodermas variably manifest as calluses, fissures, and thickened skin mainly on the pressure areas, and friction blisters may also occur. Plantar pain is an important aspect of Pachyonychia congenita, and it definitely affects the quality of life. So you can see the keratodermas is mainly focal and on the pressure area, and hyperkeratosis of the nail is the main feature of Pachyonychia congenita, and all 20 nails are not involved. The additional diagnostic findings include the follicular hyperkeratosis on knee and elbow, oral leukokeratosis, which is an important feature in type 1, palmoplantar hyperhidrosis, cyst and nails, which are important features of type 2. Laryngeal involvement may produce hoarseness in infants and even fatal respiratory obstruction. Some individuals, particularly those carrying the keratin 17 mutation, develop these steatocystomas. And this is a feature of type 2 Pachyonychia congenita. Investigation on histology. The palmoplantar epidermis shows gross hyperkeratosis with alternating ortho and parakeratosis, but there is no gross epidermolysis, which is seen in epidermolytic palmoplantar keratodermas. The cysts that are formed in Pachyonychia congenita are mainly epidermoid cysts, and sometimes eruptive hair cysts or true steatocystomas are also seen. Management. The mechanical reduction of hyperkeratosis of the nails, that is by filing, cutting, grinding, or soaking. Attention to footwear is important as orthotic supports are required to reduce the blistering and callosity formation. Effective treatment of patients with cyst is the surgical removal or incision and drainage. Emollients and keratolytics help only in mild cases. Systemic retinoid therapy is often unsatisfactory. And treatment of hyperhidrosis is sometimes essential to reduce the blistering. Then the third type of non-syndromic keratoderma is the painful hereditary callosities. That most probably encompasses many different etiological entities. In fact, the plantar callosities of sufficient size are inevitably painful. This is a feature of Pachyonychia congenita, as we have all seen. And the painful keratodermas also refer to the desmosomal diseases or to oculocutaneous tyrosinemia type 2. Oculocutaneous tyrosinemia we will be discussing in syndromic keratoderma. Other non-epidermolytic palmoplantar keratodermas is actually a heterogeneous group of non-syndromic form of diffuse keratodermas that histologically does not show the epidermolysis. Historically, the eponym of Thost Anna keratoderma is characterized by diffuse yellow hyperkeratosis. Thost Anna, then there is another keratoderma which is multimellida, which is an important differential of non-epidermolytic palmoplantar keratodermas. There are three different entities which are seen in this multimellida, that is Bothnia, the Kimonis, and the Nagashima type. It is not required that you should remember these names. Just the Thost Anna and multimellida are sufficient. The non-epidermolytic palmoplantar keratodermas may present in first few months of life and usually obvious after 2 years of age. This is characterized by yellow hyperkeratosis occur over the whole surface of the foot, starting on the heel and anterior arch and spreading later on to the palms as well. So there is diffuse hyperkeratosis that involve both the palmar and plantar skin. Sometimes this non-epidermolytic palmoplantar keratoderma may be transgradient. May be transgradient. Hyperhidrosis is usual. Dermatophyte infections and pitted keratolysis is a frequent complication. Nail, hair, and teeth are normal in these keratodermas. So this is a diffuse palmoplantar keratoderma that is seen in Thost Anna type. There is hyperkeratosis involving the whole sole of both soles of both the feet. And you can see the maceration that occurs in these type of keratodermas because of absorption of water. Biopsy served mainly to exclude the epidermolytic keratodermas. The histological changes will be orthokeratotic hyperkeratosis, that is thickened stratum corneum. There is hypergranulosis and moderate acanthosis. If dermatophyte infection is seen, then we have to exclude them by the appropriate stain. Management. The keratolytic therapy by 5 to 10% salicylic acid in WSP or gel form with 5 to 6% salicylic acid in propylene glycol 70%. If it is given under polythene occlusion, then the keratolytics work more. Low dose systemic acitretin may be tried, especially in patients with functional impairment. If the patient has superadded fungal or bacterial overgrowth, then we will treat accordingly with erythromycin or with antifungals. Topical tacrolimus may be beneficial in some cases. Then multimellida. Multimellida is a rare autosomal recessive transgradient keratoderma. Almost all cases occur in consanguineous pedigrees from families in Croatia. The problem is in transglutaminase 1 and keratin 10 genes. Onset of multimellida is in early childhood, with development of hyperkeratosis that precedes the hyperkeratosis is preceded by erythema. Then patches of waxy ivory yellow hyperkeratosis extend the whole surface of palm and soles, and then on the dorsal surface of hand and feet in glove and stocking distribution. Insular lesions that is focal lesions on knee and elbow are present in this form of palmoplantar keratodermas. Hyperhidrotic maceration, malodorous fungal superinfection is common. So Thost-Anna type is not characterized by transgradient keratodermas, while Meltimellida type, both are non-epidermolytic keratodermas, while Meltimellida is characterized by extension of keratodermas on the dorsal surfaces of hands and feet in glove and stocking, as well as lesions on knees and elbows. So this is Meltimellida, in which you can see that in addition to involvement of palmar skin, the keratoderma extend to the forearms, and here the keratoderma extend on the dorsal surfaces of feet along with anterior surfaces of the leg. So this diffuse palmoplantar keratodermas with extension to the dorsal surfaces and extension beyond the margins of palmar and plantar skin is characteristic of Meltimellida, but not of Thost-Anna. In Thost-Anna, it will be limited to palmar and plantar skins. These are the insular lesions or the focal lesions on the knees. This is also a feature of transgradient keratodermas, and here it's a feature of Meltimellida type of keratodermas. This is Meltimellida, but one of the hand palmar skin is affected by Trichophytum rubrum. So the affected skin is erythematous and is more scaly as compared to the other hand. The Meltimellida may be characterized by digital constriction, which are pseudo-anhems. There is mild nail changes like hypercurvature, thickening, and Pachyonychia. Angular cheilitis and lip involvement is possible, but it is not a feature of Meltimellida. Investigations: there is greatly thickened corneal layer, increase in stratum lucidum, and marked acanthosis, but without cytolysis, because obviously it is not the epidermolytic keratoderma. Management: the oral retinoids are effective, but hyperkeratosis may respond better than the erythema. Excision of keratosis and a split thickness skin graft is an option to relieve the functional impairment. Patient with long history of Meltimellida should be regularly seen for secondary malignancies. Then another important type of palmoplantar keratoderma is the Loricrin, keratoderma. Loricrin keratoderma is again a diffuse keratoderma, but it is specific in its shape that it is characterized by honeycomb appearance of the keratoderma, with annular constriction along the digits and mild ichthysis. In Trow-Vowinkle syndrome, which we will be discussing in syndromic keratodermas, there is impaired hearing but no generalized ichthysis. So Vowinkle syndrome has features in common with Loricrin keratodermas, but it is also characterized by hearing defect, which is not seen in the classical Loricrin keratodermas. It is because of mutation in LOR gene encoding for Loricrin, which is a glycine-rich cornified envelope protein. The clinical features include generalized desquamation, which is noted at birth. However, the ichthysis is mild and may pass unnoticed. The rugose keratodermas develop during childhood and gradually forming a confluent honeycomb pattern. The edge of keratodermas are diffuse in contrast to Vowinkle, and cicatricial band pseudoanem may develop around the digits. Knuckle pad and warty keratosis have been reported. So you can see this Loricrin keratoderma, which is characterized by honeycomb appearance of the keratoderma, of the diffuse keratoderma. In addition to hyperkeratosis, hypergranulosis, there is parakeratosis as well. Successful management is with isotretinoin and by vascular endothelial growth factor receptors. Then striate and focal palmoplantar keratodermas. The isolated striate palmoplantar keratodermas is transmitted as autosomal dominant trait with at least 3 different genes are involved. And these keratodermas are characterized by cardiomyopathy in some cases. Several distinctive keratodermas with striate or focal patterns are recognized and may be associated with some syndromic entities. The striate hyperkeratosis is particularly not associated with keratinocyte disadhesions. Mainly the desmoglein 1 and desmoplakin gene are involved in the striate keratodermas. As described before, the striate lesions are characterized by linear keratodermas that involve the flexor aspects of the finger and the digits and the flexor tendons. And the linear pattern of skin thickening is seen on palmar and flexor aspects of the fingers. On soles, the lesions are more areate or confluent rather than striate. Mechanical stress is important and pain and hyperhidrosis occur. Woolly hairs and possibility of cardiac disease should be considered. So you can see here that the lesions on the palms are mainly striate, that the linear lesions, but lesions on the foot are mainly of areate or punctate type, areate type. Investigation. This addition of keratinocytes with widening of intercellular spaces is important histological clue. Management. There are several reports of good response with systemic acitretin therapy and by application of urea creams. Then punctate palmoplantar keratodermas. This punctate palmoplantar keratoderma is in autosomal dominant inheritance and is characterized by small round papular lesions on palmar and plantar aspects and coalesce over the pressure point. Initially translucent with depression in the center, but later opaque and warty. The onset appear early in adolescence, but may extend up to the 6th decade. Small and large lesions coexist, including the broader focal plantar callosities, and it is seen in more commonly in the manual workers. There is no involvement of dorsal surface of hands or leg, nor the knees and elbows. It is not clear whether the punctate palmoplantar keratodermas are truly associated with malignancies. So if you can see closely, you can see these punctate lesions. The small punctate round lesions are seen on the plantar aspect of both the hands, palmar aspects of both the hands. If we do the histology, there is well demarcated depression with thick hyperkeratosis and hypergranulosis. So these are the histology of a punctate lesion. Management. Then careful choice of footwear with regular use of Primostone to remove these punctate keratosis. No major beneficial effect of keratolytic ointments as well as topical retinoids and topical calcipotriol. Systemic treatment with oral retinoids may yield small effects. The spiny keratoderma. Spiny keratoderma is a rare condition of unknown etiology and exists as benign hereditary idiopathic form. The spiny keratoderma is characterized by 1 to 2 mm papules, which are described as the filiform spiked prickly digitate and project from palmoplantar skin. Has an autosomal dominant trait and lesions are seen in early childhood. So the spiny keratodermas are even smaller than the punctate keratodermas with spiny appearance, small keratotic lesions. There are different disorders which are characterized by this spiny keratodermas, where these disorders include the Darier's disease, epidermodysplasia verruciformis, arsenical keratosis, multiple filiform warts, and paraneoplastic follicular hyperkeratosis. Mechanical debridement with dermabrasion may be more effective than the topical keratolytic. Etretinate or acitretin have a temporary effect. Topical 5-fluorouracil ointment may be tried with variable results. Marginal papular keratodermas. So these keratodermas, as the name signifies, is characterized by involvement of marginal skin. There are two types referred as acrokeratoelastoides as well as focal acral hyperkeratosis. Both are characterized by papules and plaques and nodules located at the junction between the palmar and the dorsal skin of hands and feet. It has an autosomal dominant inheritance. The pragmatic division is into a hereditary type. The hereditary type is characterized by elastorhexis, that is disruption of elastic fibers, and is referred to as acrokeratoelastoides. While the other type, which is not associated with elastorhexis, is called as the focal acral hyperkeratosis, and it develops later on. So these kind of hyperkeratosis is seen at the marginal skin. Punctate keratosis of the palmar creases. As the name signifies, this peculiar type of punctate keratoderma involve only the creases and seen in Afro-Caribbean black individuals and transmitted by autosomal dominant fashion. 1 to 4 hard warty lesions confined to the palmar creases. Around 1/3 of black individuals may show hyperkeratotic pits involving the flexural creases of the palm. The keratoelastoides marginalis is an acquired condition that presents with collagenous plaques forming linear bands, principally around the web of thumb and index finger. There is histological evidence of solar damage as well. So histology, there is focal orthohyperkeratosis. The key microscopic finding is acrokeratoelastoides is the presence of massive elastolysis. But in focal acral hyperkeratosis, there is no elastotic fiber disruptions. Cole's disease is a genodermatosis that is characterized by punctate keratodermas as well as hypopigmented macules on the extremities. Ultrastructure analysis shows a defective melanosome transfer from melanocytes to keratinocytes. And this disease manifests in the first year of life. And epidermolysis bullosa simplex with mottled pigmentation is the closest differential of the Cole's disease. Transgradient echogenic keratoderma is a peculiar type of keratodermas that is characterized by mild keratodermas, but it is triggered or exacerbated by contact with water or sweat. Most cases of transgradient echogenic keratodermas are acquired, but autosomal recessive and dominant cases are also seen. The disease is associated with use of cyclooxygenase 2 inhibitors. Affected individuals are 6 to 45 years of age and mainly women, with subtle keratodermas that appear after a few minutes of immersion of hands in water and after sweating. One characteristic sign of this echogenic keratoderma is called as the hand in bucket sign, that the patient bring the vessel to demonstrate this keratodermas to the doctors. The painful burning or itching, whitish papular lesions are associated with acrosyringeal ostia, dilated acrosyringeal ostia. The lesions subside shortly after drying, leaving minimal hyperkeratosis. Histology showed dilation of eccrine sweat glands. Treatment is by reduction of sweating by use of 20% aluminum chloride, hexahydrate, and botulinum toxin may also result in improvement. So you can see this this swelling of the palmar skin on immersion in water. Then in the last, we are going to discuss a few acquired keratodermas. Callosities or more extensive thickening of plantar epidermis is commonly seen in obesity and with increased age and in those patients who have orthopedic problems, that is, have some defect in the bony structure of the feet, that result in formation of thickening or callosities at the pressure areas. There is a common type of acquired keratoderma which is called as keratoderma climacterum or Hoxthausen disease. This entity is described more commonly in women of age more than 45, and it is associated with obesity and hypertension. Pressure areas of heel and foot are first involved. Heavy hyperkeratosis with fissuring make walking painful. The hyperkeratotic areas gradually extend to become confluent, involving the entire plantar and palmar skin. There is a report of 0.5% estradiol in water in oil base is successful in treatment of this keratoderma climacterum. Acetretin may be helpful. So this is climacterum, keratoderma climacterum. There are many inflammatory disorders that are characterized by keratodermas. One of the most common inflammatory disorder is psoriasis, which is characterized by both the diffuse and centri-palmar hyperkeratosis, that is involving the center of the palmar skin. There are special type of keratodermas that is associated with psoriasis, which are called as the caryocinar lesions. These are the depressed plaques seen on the margin of the fingers. And these are characterized by a central depression and surrounding raised margins. Then in reactive arthritis, the keratodermas is characterized by the keratodermas are heaped up and are known as the keratoderma belanologicum. You can see the heaped up keratodermas. These are the punctate type of lesions and seen in Rieter's disease and other reactive arthritis. Then there is hyperkeratotic eczema, which is involving the palmar and plantar skin, which is differentiated from other type of acquired inflammatory keratodermas by presence of itching. Then orange hyperkeratosis of pityriasis rubra pilaris is associated with other findings, that is the acute follicular eruption, areas of sparing on the skin. And this is a characteristic orange color, which is seen in diffuse palmoplantar keratodermas of pityriasis rubra pilaris. In lichen planus, the lesions are punctate and can be mistaken with warts. So these are the punctate lesions seen in punctate keratodermas seen in lichen planus. And you can find the other lesions of lichen planus on the ankles, on the wrist, and maybe in oral mucosa. Acquired palmar and plantar keratodermas are seen in fungal infections, mainly due to Trichophyton rubrum. But this is characteristically unilateral and lack the inflammatory sign. So here, this is a unilateral involvement by Tinea rubrum, Trichophyton rubrum, with hyperkeratosis, also called as hyperkeratotic tinea pedis. Then secondary syphilis is characterized by punctate psoriasiform lesions on both the plantar and palmar aspects. Tropical diseases like late jaws is characterized by punctate keratodermas, which are mainly present on the pressure areas. Then warts may be seen in immunocompromised patients. Many warts are seen on plantar and palmar skin that can result in painful walking. Then crusted scabies is characterized by thick and hyperkeratotic lesions with thick crust on palmar and plantar aspects. If you see the nails, this type of crusting is also seen beneath the nails. So these are the characteristic findings in cases of crusted scabies. Mixed edema and lymphedema. The palmoplantar hyperkeratosis is seen in mixed edema. And If we treat the hypothyroidism, the palmoplantar keratoderma improve. In chronic lymphedema, the skin overlying the lymphadematous area become diffusely thickened and then develop into velvety papillomatous surfaces, which are covered by large irregular warty projections. This is called as the mossy foot. This is a mossy foot. Lymphadematous keratodermas occur most characteristically in filariasis, but may develop in chronic lymphedema of other origins. Both hyperkeratotic component and the lymphedema improves by use of acitretin. Malignancies are characteristically associated with palmoplantar keratodermas. This is called as the tri-palm or the basics acrokeratosis paraneoplastica. So this is tri-palm, that is thickening of palmar and plantar skin that is associated with malignancies. And different type of tumors such as those of bronchus, breast, colon, and kidney are associated with this kind of presentation. Mycosis fungoides is one of the important cause of acquired palmoplantar keratoderma. Carcinogens, of which the best documented example is arsenic, produce keratodermas as well as the internal malignancies. So, increased incidence of keratosis in patients with lung and bladder cancers has been debated. Smoking and papillomatous infections are, and papilloma virus infection are the suggested culprits. Drugs. Keratodermas may be seen in patient receiving iodine, glucan, lithium, tagafur, and halogenated weed killers and digoxin. Arsenical hyperkeratosis is one of the characteristic type of keratodermas which we see. This is again a focal or punctate keratoderma which is seen in arsenical hyperkeratosis. So that's all for today. And if you have any questions regarding this chapter, you can inbox me or you can ask in the forums in which I am posting this lecture. Thank you all and have a good day.